Sir, we are live now. With all your permission, sir, I am starting this session for the
Yes,
first.
please.
Good afternoon, everyone present here. I am Faraz from IJCP Group. Welcome all the participants in today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Bansi Sahu, sir. And let me share some of the achievement of sir. Sir has done MD, PhD, Chief of Diabetologist, Chairman of Diabetes Care and Hormone Clinic, Ahmedabad, and Chair-elect IDF South Asia. And today, sir is going to speak on a very important topic, that is decoding 30 years of post-DCCT insight that transform diabetes care. By taking not much time, I would like to invite sir and hand over this session to sir. Sir, stage is yours. You can proceed from there.
Thank you. It's my great pleasure to talk on a platform of IJCP, and I am thanking all the delegates who are participating today for this meeting. And I'll be also live. This presentation will be there later on. Also, people can listen. It's very important that after DCCT of 30 years, what's this changing scenario in our country? Let me start with my first slide with no disclosure. I don't have any financial disclosure, but I'm involved with person with diabetes with a lot of type 1 association around the world. And recently, Government of India put me in a technical committee of diabetes under Health Ministry. Now, 30 years before, when DCCT was published in 1993, the same time almost, my journey in the field of diabetes started. As I had started my residency in 1995, I was second year resident, and since 2025, since last 30 years, I'm practicing diabetes. But over a period of 30 years, if you see what we used to do, urine monitoring, occasionally blood glucose monitoring, urine ketones was, or strips for urine sugar strip was available only. That was very occasional use of self blood glucose monitoring. A1C was not for everyone. Regular follow-up was a dream. No records, no data. And annual screening for complication after 5 years of diagnosis of diabetes was almost non-existent at that point of time. While now almost everything is changed, everyone on SMBG, but still people have not improved as far as their target achievement in type 1 diabetes. This is the data of type 1 diabetes. We are not highest incidence wise. North America or northern part of Europe have much higher incidence in compared to what India or China have. But still, the number of people with type 1 diabetes, we are the one highest in the world. We are having 24,000 people every year are added in this list. And we are not in the top 10 countries as far as incidence is concerned. Diagnosis, before that, it is only the clinical diagnosis. The patient who have presented with diabetic ketoacidosis, normally we understand they are type 1 diabetes, but ideally, if we can get their autoantibody, if we can get their C-peptide, probably you can pakka case of diagnosis you can do with these investigation. So diagnostic criteria was considered with the history of decay, but that's not true. Ideally, they should have autoantibody and C-peptide level. DCCT trial had shown that tighter the control, the better the outcome, less the complication. But to get tighter control, a lot of hypoglycemia. And probably we understood that hypoglycemia is a limiting factor very well. But that is the one of the other reasons that sometimes because of risk of hypoglycemia, we are not able to achieve a tight glycemic control for most of our patients, that we are worried. But if you see the long-term data of DCCT and ADIC study after 30 years, they had shown that intensive control in early in the course of diabetes will give them lifelong protection of controlling their sugar, will have less and less complication throughout the lifetime. HbA1c, at that time, they could achieve around mean A1C of 7.2. But post-ADIC study, most of these two in the intervention arm as well as with the patients who are on a regular arm, both of them were achieving targets of around less than 8. Because what happened, those who are intensively controlled, they become less intensive. And those who are in the follow-up, I mean in the control group, they understood the importance of tight control. And this is how now the average had started becoming around 8 or 8.5. What is more important in this DCCT trial, what we have seen, patient normally with first 10 to 15 years of their diabetes, they don't develop complication. It is the complication starts after 10 years of type 1 diabetes. And this is very important from a pediatrician point of view, because they don't see a patient with a diabetes complication. In first 10 years, they don't develop complication. That's the reason they can never become a very intensive diabetologist or an intensive control diabetologist. While a adult physician, when they see the patient, already patient have a history of diabetes with 10 years, a lot of have developed already the complication. This is how a type 1 diabetes to survive, they have to take 1460 shots in a year, and almost similar number of times they have to prick their sugar also. A type 1 diabetic patients taking more pricks, more injection, and more checking the sugar will have better control. So it's a time that we have to change the mind of caregiver and the patient and the doctor, that better A1C you can achieve with a more number of pricks and more number of sugar monitoring. That's the only way by which we do. We educate the patient only once in a year, twice in a year, 3 times in a year, while patient has to live his life with 24 hours by 7. And how it can be done? With a lot of education we have to give, because he has to live with the family, he has to live in the school, he has to live in the society. So multiple times he has to adjust his lifestyle in that way, and that requires a lot of education that we should give in that one consultation of 3 months or 6 months. And every time this education should be intensified whenever a patient comes to you. The goal is very, very clear, that you try to achieve a tighter and tighter glycemic control with less and less hypoglycemia, or rather no hypoglycemia. We don't want our patient to go in hypo, neither in diabetic ketosis. And that is our primary target or achievement of a goal in a person with diabetes. This is one paper which we have written long back about the awareness, management, and challenges scenario in India in last 15 years. The scenario was very bad. I mean, before 15-20 years, but things have not improved so much. Still, it is better, improving over a period of time. But this data which shows that in an Indian person with the diabetes who is developing below the age of 10 years, normally or roughly, they can have a good quality of life only for next 15 to 20 years in between. Most of them, they die early. And why India looks like this? Because of we provide them pre-mix insulin. We provide them less number of time monitoring. If we can just change it from premix to basal bolus, if just giving them a strips on a regular monitoring basis, probably many of them will have a good quality of life, and they can survive not for 28 years of age, maybe up to 54 or 55 plus, they can have a normal life. Even if we don't provide them the advances like insulin pump or like a continuous glucose monitoring. DCCT chairman had told very clearly that intensive diabetes treatment is not just more insulin. And this is commonly done by our pediatrician or colleagues, that they when see the patient who is uncontrolled diabetes, they just try to increase or decrease the dose of insulin. It is require more education. It's not the intensive treatment does not mean increasing more insulin. Intensive treatment mean more intensive education for reducing hypoglycemia and for better control of diabetes. Type 1 diabetes management, if you see in last 35 years or 40 years, nothing has been changed. They need basal bolus therapy, they need self-monitoring of blood glucose, they need diabetic education and counseling, and they need regular follow-up to prevent comorbidities and complication. What are the key challenges? Key challenges is low awareness, delay in decision to seeking care. Diagnosis is the right time of diagnosis is very important, and then to educate the patient to start the insulin therapy, but they have unwillingness for initiating and intensifying therapy. If you start them teaching about the initial treatment and management, they will able to understand in better way. And then a life with type 1 diabetes, that also we have to continue to educate them, because socially they should have less and less stigma, and the language which is also very matters for them, because they are non-diabetic, rather we call them person with diabetes. That's very important. This is one more recent paper which we have published about the what the status of in Southeast Asia. Southeast Asia, if you just see the different countries, almost status is same, except then few countries are more poor, may not able to have insulin available. But in India, now in the tertiary care hospital, we started giving insulin almost free, but most of the private sector people are, even with the foundation help and others, also we try to give the patient insulin injection, glucose meter strips and all those things. But they have a lot of type 1 diabetic patients and require more education, more intensive therapy for a better quality of life. This is what the SPAD guideline, where we are the part of SPAD guidelines since last almost 10 years. And every time we write from the developing countries, what are the things which we need in our developing countries, how the guidelines should be made. And on that basis, Indian societies like Diabetes India, RSSDI, ISPEI, even national guideline ICMR, they are based on those guidelines which are internationally available. This has really changed the way we have treated type 1 diabetes in our country. This meeting I could bring India in 2018. In last 7 years, I can definitely see the scenario for type 1 diabetes is changed for that. We had also become the part of SWEET registry. We are the only one who is outside Europe to have this registry of type 1 data. We have more than 1700 patients to whom we are regularly putting in this registry also. Now, why continuous glucose monitoring is required if patient is already on SMBG? I just given a simple example. If some patient who is on SMBG 3 to 4 times in a day, you find that sugar is well controlled. But when you do the CGM, you will find the pre-lunch actually sugar is going down and post-lunch actually sugar is going up also. So this require a continuous glucose monitoring for our patient. If you have a DCCT trial, as I told you in 1983, after 25 years, the same patients who are put on a continuous glucose monitoring, you can see the risk of hypoglycemia significantly decreased from 62 to 20. So the importance of CGM is really very, very high in patients to decrease the risk of hypoglycemia, and still you can achieve a better glycemic control. On this, we have put a consensus using continuous glucose monitoring all over the world. All type 1 should be on CGM. And on that basis, if you are putting patient on continuous glucose monitoring, instead of going for HbA1c, which is once in 3 months, see every day what is the time in range, how much time a person is actually having his sugar between 80 to 180. And that's what we call is time in range. Time in range is the one concept which has been given, that instead of HbA1c, now you follow time in range and put the patient on continuous glucose monitoring. Sometime when we put the patient on continuous glucose monitoring, particularly type 1 diabetic patient, we find the patient is actually on 2 different days are behaving completely differently. Even their lifestyle is same, but still they're continuously, they may have different hypo and hyperglycemia. Even a patient to whom even midnight sugar you want to do, even 4 different days in the same patient, it could be different also. So how to treat those patients if they have multiple such type of hypo and hyperglycemia on a continuous glucose monitoring? And that's the reason one paper which was published by UK, that even after putting all the patient on CGM on a type 1 diabetes, less than 70% of the patient were actually achieving, less than 30% of the patient were achieving tight glycemic control in type 1. It means CGM alone is not enough. And we need to put the patient on a pump, because we need to put the pump for multiple dose adjustment of giving multiple bolus. At the same time, the basal also dose we can adjust for these patients. We have a lot of practical issues. One of the biggest issue is cost in our country. It is the education which is required, but internationally now it is recommended with evidence A that all patients should be put on a sensor augmented insulin pump or automated insulin delivery system. They have a data again in 2016 which had shown that patients to whom we want to put on insulin pump, they can achieve not only less than 7, but with the risk of hypoglycemia 0. And that's the beauty of this insulin pump, that they can achieve HbA1c of less than 7 without even hypoglycemia. So what we are seeing is those patients who are on a different modes of insulin therapy, even with the blood glucose monitoring, actually they are not achieving time in range more than 70%. What we need is advanced insulin delivery system, that is advanced hybrid closed loop system, which is 780Z, and out of them, if you put them, 75 to 79% of the patient will achieve that control. We have put a lot of patients on type 1 diabetic patient on insulin delivery system also. And at present, I have written in one paper also a call to action that all people with type 1 diabetes should be on insulin pump therapy, and if we are not putting on them, we should document that thing in medical record. We know that everyone can't afford, so we have to educate them more, because they are not having a lot of resources. But those who can have good resources, at least they should be provided with this. We understand the bridging the gaps in diabetes care, equality and equity, two very important difference. We wanted to provide everything a equal level of education education, but some of our patients who are not affording, they don't understand the importance of it. We have to give them equity. I mean, you educate more those who need more, and according to their psychosocial status as well as economic status. That's what equity is there. Despite multiple advancement, there are many barriers in life with type 1 diabetes. We have to deal with all of them, and one of the biggest is lack of awareness at community level. And I think if we can improve that, I think many of the aspects of type 1 diabetes in India can be taken care. Definitely, it requires a lot of holistic approach with a lot of language, which matters for that. But advocacy and support are the key. That's our most important thing. And I think the government can do a lot of things for improving the care for these patients. So my key recommendation is establish a robust national type 1 diabetes registry, expand subsidies and healthcare coverage under NPCDCS, foster innovation through public-private partnership, enhance public awareness and reduce stigma via education, campaign, scale up AID system and CGM adoption to your patients. To conclude my talk, DCCT insight remain clinical in shaping type 1 diabetes care. Addressing gaps in affordability, accessibility, awareness is essential. Leveraging the policy reforms and innovative technology can transform outcomes, and India has the potential to become a global model for managing type 1 diabetes in its own constrained setting. With this, I thank. We know that we can't do everything for type 1 diabetic patients, but our role is like a healthcare professional, like a coach. The child has to play. He is the player, but we have to be like a good coach who can constantly teach and educate our persons with type 1 diabetes. With this, I thank and I invite all of you for World Congress of Diabetes, and those who are really interested to know more about type 1, more about the advances in technology, they can join us in DTech meeting in 9 to 11th May at Jaipur. With this, thank you. Thank you very much. If I have any question, I'll be very happy to answer anytime. Yes, dear.
Yeah, thank you so much, sir, for taking out your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, as I can see, sir, we don't have received any question. Once feedback from Dr. Anshu. He has written a wonderful talk and like a wonderful presentation, and one from Dr. Subramanian. Thanks for amazing presentation.
Thank you.
Thank you so much, sir, and we would like to see you in future also with